All right, everybody, welcome to our April Roundtable discussion. I think we have a record 13 or 14 Zoom participants today. So I think we have more people on Zoom than in the room, which is exciting. So this quarter's presentation is on early intervention for psychosis in Hawaii, updates on the coordinated specialty care model. We'll start off with a presentation by Dr. David Cicero, and then we'll open it up to discussion from Drs. Sheehan and Alicata, but I'll first just introduce David for now. Okay? And then, Dr. David Cicero is a licensed clinical psychologist, the director of the On Track Hawaii First Episode Psychosis Clinic, and an associate professor of psychology at the University of Hawaii, Manoa. His research focuses on developing and refining methods of assessment for early and prodromal psychosis to improve early identification and treatment. Professor Cicero earned his master's degree at the University of Virginia, PhD at the University of Missouri, and completed his pre-doctoral internship at the VA Maryland Healthcare System / University of Maryland School of Medicine Internship Consortium. In addition to clinical psychology, he completed a graduate minor in quantitative psychology. He's been at UH since 2012. And with that, let's give Dr. Cicero a warm welcome. So we'll start off with this presentation, and then we'll introduce the panel, and then we'll kind of flow into the discussion. Is that okay, David? Okay. And then, a quick announcement for the 13, 14 people on VTC. If you can see the slides, you can see Dr. Cicero's slides if you go to Help Your Keiki, then Resources, then What's New. We buried it there, it's like 4D. Help Your Keiki, Resources, What's New, and then upcoming EBS Roundtable presentation. And you can see, you can kind of track what David is doing. But then one last thing, David, if from time to time, if you could just maybe give markers like, I'm on slide 3, or moving to slide 4, or something like that. Okay, thank you.
Well, thank you everyone for inviting me to come talk today. And I realized in preparing for this presentation that the last time I talked at this was a little bit less than 3 years ago. So it was after we had started preparing, but before we had admitted any clients. So I'm excited to come back and kind of talk a little bit about what we've been doing and some of what the updates have been kind of on a national scale as well in terms of early intervention for psychosis and schizophrenia. So I'm going to start off today talking a little bit about what the rationale is for our program and what the purpose of our program is. And then I'll talk a little bit about some of the more recent developments. So since the last time I talked about the recovery after initial schizophrenia episode, which is the NIMH study that kind of led the way for the coordinated specialty care clinics, which are all over the United States now. Then I'll talk a little bit about our program at On Track Hawaii and kind of what we've been doing. I'll have a little bit of information about preliminary outcomes in terms of how our clients are doing and where our clients have come from and those sorts of things. And then finally, one thing I want to make clear throughout today is that I really want to hear feedback from you guys about what needs there might be that we haven't been able to address, or any potential problems, or just any kind of feedback. We would be really interested to hear that. And so as Brad said, I'm going to talk for a little bit, and then we're going to have more of a roundtable discussion. If you have any questions for me throughout the presentation, feel free to ask throughout as well, and we can kind of go from there. So schizophrenia has a prevalence rate of about 1%, and this is pretty constant throughout the world. And one of the issues with schizophrenia and why it's such a major problem is that only 10 to 15% of people with schizophrenia actually work and have jobs. So at this point, I'm talking about adults with schizophrenia. And the most recent estimate of cost that I could find is that it costs the United States $155.7 billion a year. So that includes the direct costs of providing treatment to people who have schizophrenia, but also the loss of productivity because people with schizophrenia, most of them are not working. And so I'm going to talk today about how one of our goals in our program is to get people back on track at work and school. And so that's one of our primary outcome measures that we're going to talk about is in our sample, it's mostly school because we're working mostly with with high school and college age kids. But work is also very important for these types of programs. So in terms of intervention, we know that there's an undertreatment of mental disorders in youth compared to older adults. And we also know that the duration of untreated psychosis is related to poor outcomes. So the longer a person goes from having their first symptom of psychosis to the first time they are provided with adequate treatment, the worse their prognosis tends to be. So the goal of our program is to identify people earlier, provide them appropriate treatment, and then hopefully improve outcomes. For those following along on Zoom, I'm on slide 5 now. So this is a chart of the mental health prevalence versus service gap for across ages. So what we know here is that people younger, so adolescents and early adults, have the highest rates of mental illness, but are among the lowest rates of actually seeking treatment. So there's a big gap here, and thankfully it starts to shrink as we get into adulthood and later adulthood, but at the same time we're really kind of missing it in these younger folks. And at the same time, if you look at the health burden of different disorders across mental disorders and cancer, cardiovascular, other types of problems, you notice that the health burden is the largest. The health burden of mental disorders is the largest among younger people. So there are several different kind of theories about how to intervene early with people with schizophrenia. And so schizophrenia is thought to have several different phases. So starting with the premorbid phase on the left, which is kind of the period from birth until the individual starts experiencing symptoms. There are some kind of premorbid markers that we've been able to identify in these younger folks, but they're not really having any symptoms that you can point to and say these are symptoms of schizophrenia. The next phase is the prodromal phase. In this, you may remember there was a big debate in the DSM-5 about whether to include an attenuated psychosis syndrome in the manual, and that's really what we're talking about here with this APS. And at this point, we're still talking about preventing schizophrenia or preventing psychosis from ever developing, or at the very least, kind of intervening very early so that we can improve the course. And then the other approach is intervening here in this later stage of early psychosis, so after somebody has already converted to psychosis. So this is what we would think of as schizophrenia when someone's in the hospital or is actively hearing voices and seeing things and having delusional ideation. So with the, so you may know, and I'll talk a little bit more about this later, that our program is funded through the Substance Abuse and Mental Health Services Administration through the block grant that the Hawaii Department of Health has. And so SAMHSA has kind of given us a mandate for what kind of treatment they want us to provide. And their idea was that we want to identify people kind of as close to this line as we can, but after this line. So people have already developed schizophrenia. And from my understanding, the reasoning for this is that it's a limited resource, and we want to identify people who really need it. And if you identify people in this APS, best estimates suggest that between 20 and 35% of the people who are identified as prodromal actually go on to develop schizophrenia. So we're still talking about the majority of people not developing schizophrenia. Treatment helps, but it's not as dire a need as it is as for these folks. So if we follow the SAMHSA mandate very closely, then we're really focusing on people who have already converted to psychosis or schizophrenia. And the idea here, again, is that when people develop schizophrenia, so this is the premorbid phase and then the prodrome, that there's a drop in functioning. And this is probably pretty obvious because people in these cases often need to go to the hospital or need kind of long-term serious treatment. And the idea is that the further we allow people to fall, then the bigger hill there is to climb. So the idea is catch people earlier before they get too far down, and then we can get them back on track and back functioning as well as they were. So again, to spend just a little bit more time on this idea of duration of untreated psychosis. So there have been a few meta-analyses about the duration of untreated psychosis and how this is related to outcome, and there are a couple potential mechanisms for this. I think Dr. Alcott has actually done some work on this too, and kind of looking at there could be these there could be an active morbid process, right? So where it's actually damaging the brain and people not getting that treatment, or it could be more of a psychosocial toxicity hypothesis where people are, they need to be hospitalized, so they're missing out in school, they might be isolating from their friends and family. And so the hill to climb in that case is just kind of getting back into school, getting back into work, and reestablishing those relationships with friends and family. So this meta-analysis has found that, so I don't want to spend too much time on this, but the basic take-home message is that people aren't that different in their first episode based on duration of untreated psychosis, but it does seem to have an impact at 6 months, 12 months, and on to 2 years after that initial treatment. So this just kind of underscores that it's really important to provide these services as early as possible. I also wanted to provide a little bit of a context for what's been going on kind of globally in terms of early intervention for psychosis. So this has been going on in Australia and Northern Europe in particular for a couple decades, but the United States was really kind of behind. And there were a few reasons for that. One being that it wasn't necessarily a priority in terms of using public money to pay for these types of services, but there were also some insurance issues related to that. So most young people would qualify for a service like ours through Medicaid, but to get Medicaid, you have to already be disabled, and kind of by definition, we're trying to intervene before people would get to that point where they would qualify for Medicaid. And also before about a decade ago, it was difficult for young adults to still be covered by their parents' insurance, right? So there was really no kind of way to pay for this. This led to kind of some research in the United States about how to better provide treatment and some recommendations. So this is just with chronic schizophrenia. The recommendations generally were specific types of antipsychotic medication, vocational rehabilitation, family support, individual and or group CBT, and social skills training. The next step kind of in this process was the Recover After Your Initial Schizophrenia Episode study, which was a major study at several different sites and throughout North America and the United States mainly, looking at whether this coordinated specialty care model that I'll describe in more detail in a little bit could be effective in treating early psychosis. I'm on slide 14 now. And this was the first outcome study of the RAISE trial. So a couple of important things to notice here. So this Navigate was the name of one of the RAISE models that was used. So when we're talking about Navigate here and comparing that to community care, that Navigate is kind of active treatment and community care is the treatment as usual. And one interesting thing that they did was that they randomly assigned clinics rather than individuals within clinics, because they wanted to make sure that people were actually getting different treatment. So if you have people in one clinic who know how to do both treatments, it's going to be really hard for them to not to do treatment as usual with one and then the new treatment with the other. And so as a result, the groups weren't completely matched at the beginning. So this on the left here is the quality of life score, and throughout the model, really quality of life is seen as the most important outcome as opposed to symptoms or anything like that. It's really focused on kind of improving quality of life. So as you can see here, the RAISE group kind of started out worse than the treatment as usual group, but by the end they actually had higher quality of life than the other group, suggesting that this model works. On the right here, this is one of the most commonly used scales for psychosis symptoms, the positive and negative syndrome scale. You can see that the RAISE group had higher scores at the beginning and then ended up with lower scores at the end. Another interesting thing I want to point out is duration of untreated psychosis. So here, the solid lines are people with short duration of untreated psychosis, and the dotted lines are people with long duration of untreated psychosis. You can see that really where a lot of the improvement came in was in people who had shorter durations of untreated psychosis. And so this is in quality of life, and you see the same pattern here with symptom outcome. Right, so this again highlights this need for early intervention and where we're really catching people early. So not just by age, but by duration of untreated psychosis.
What's the definition of the short duration?
So in here, it was 74 weeks. A year and 2 or 3 months. The last result from the RAISE study I want to mention is this perceived autonomy support. And so you can see that there were not much differences at the beginning, but there were differences by the end of the 2-year study. And so I think this is really important because it's showing that the individuals who were in the study were feeling like they were being supported to become supported in their autonomy rather than kind of more managed. So this brings me to our clinic, the On Track Hawai'i clinic. So we have developed a coordinated specialty care clinic, and we've partnered with the Child and Adolescent Mental Health Division, the Adult Mental Health Division, and with the Department of Psychiatry at the University of Hawaii. So there are a lot of people involved in getting this up and running, and a lot of people involved in continuing to support it and making sure that we're getting the referrals that we need and having the resources that we need to continue. We are close to moving to the Ala Moana building. We're currently located in the Center for Cognitive Behavioral Therapy at the University of Hawaii campus, and we're going to maintain our spot there too. But we're moving to the Ala Moana building on the 15th floor. So we're hopefully in the next few weeks we'll be in there. And the idea there is that it'll be much easier for our clients to get to us and the families that we work with. Parking is hard at UH, and also the bus routes aren't as easy, so it'll be much easier. It's more centrally located. So we're really excited about moving there. There's a little bit of an ocean view if you kind of put your head against the window and lean in close enough. Our other place is at the Center for Cognitive Behavioral Therapy, and I'm sure everyone in this room is familiar with the Center for Cognitive Behavioral Therapy. So as I'm going to talk about in a little bit, we do have a lot of clients who are UH students. So for them, it is easier to just come and see us on campus. So we're going to continue that option as well. So the Center for Cognitive Behavioral Therapy has 3 programs, which most people are probably familiar with. The Child Division, which Chuck and Brad run. The Eating Disorders Clinic, which Kelly Tuzik runs, and then the First Episode Psychosis Program, which we're talking about today. So our clinic is designed for people between the ages of 15 and 24 who have a recent onset of psychosis. I want to mention here too that we're flexible on this. It doesn't have to be, so if you have a 14-year-old, that's fine. If you have a 25-year-old, that's fine. I don't know that we would go lower than like 12 or so, but we are flexible on this. So we want to make sure that we're meeting the need, and my understanding is that SAMHSA is okay with that. When we first started doing this, SAMHSA was pretty clear that they wanted us to focus on non-affective psychosis. So by that I mean schizophrenia, schizoaffective disorder, other psychotic disorders, but not bipolar disorder with psychotic features or major depression with psychotic features. They've changed on that. So we now are accepting referrals for bipolar disorder with psychotic features. I want to make sure that's clear. I'm going to say it again a little bit before we end. Or in major depression with psychotic features. Those are fine. And a little bit of background on that, the SAMHSA's attitude at the beginning was that the evidence base wasn't there for those other disorders, but it's evolved a little bit in that, the medication treatment might be a little bit different, but the psychosocial stuff would be pretty similar. We're also flexible on this 2-year cutoff, so we tend to identify, First Episode is 2 years. So if you have somebody who's been identified for longer than 2 years, please refer them too. We're still limiting it to people on Oahu, and that's mostly for logistic reasons. We've had some talks about expanding that as well, but we're not quite there yet. And I'll let everybody know when we are at that point. So a couple of principles of our model that I want to talk about are the recovery model and the coordinated specialty care model. So the recovery model focuses on quality of life rather than symptom reduction. And we treat every client with the attitude that we're optimistic about recovery from schizophrenia. And the data suggests that a lot of people do have psychotic episodes when they're younger and do recover and do well later in life. We also focus a lot on employment and education, and as we'll talk about in a minute, it's mostly education because all of our clients are in school. But we also focus on reestablishing a sense of identity for people who have been hospitalized, and an identity that's separate from the illness, reduction of stigma, and then we use a shared decision-making model. So rather than telling clients what they should do, we work with clients to develop a collaborative treatment plan to use moving forward. And I think probably, when I give these talks, I think most people agree with the recovery model, so I don't want to contrast it too much with other models of treatment because I think this is pretty much what everyone is doing these days. But it's focusing on quality of life again and less on reduction of symptoms, and then taking a biopsychosocial approach as opposed to biomedical approach. Sometimes with schizophrenia, people tend to think about it as more of a biological disease and focus more on medication. And medication still is the primary treatment and the most effective treatment, but these other aspects are also important. So our coordinated specialty care model includes 5 components. So we have at the top here, medication and primary care, psychotherapy, family education and support, supported employment and education, and then finally case management. The treatment team includes me as the director, Dr. Alicata as the prescriber, and he supervises residents who are also involved in prescribing medications. Elsa is our clinical supervisor, and then we have UH clinicians who do the individual therapy, the supported education and employment, and case management. So these are all master's levels advanced graduate students. So again, the pharmacotherapy that we do is with Dr. Alicata at in partnership with the Department of Psychiatry at the School of Medicine. And I won't say much about that. I'll let we can, if you have questions about that, we can talk about that during the discussion portion. So our psychotherapy is very much just based on cognitive behavioral therapy. So it's really not a lot different than doing cognitive behavioral therapy with any other child or adolescent or young adult. There are a couple of things that we do in terms of reality testing and things like that if somebody has a delusion, and a couple kind of different things we do for hallucinations, but mostly it's very similar. It's more similar than it is different. We emphasize resiliency training, illness and wellness management. So by that I mean we do things like come up with a plan for what should happen should they have another psychotic episode. Where would they want to go to the hospital? Who would they want to contact? General kind of safety planning, but focus on psychosis. And then we focus on general coping skills. So this is provided by clinicians at the Department of Psychology, and as you know, we're very committed to evidence-based services at the Department of Psychology, so our students get very well trained in cognitive behavioral therapy, which I think kind of positions them well for a clinic like this. I think there are also some extra advantages of this as well. I think it's really important that our clinicians, or at least some of the people involved in our care, are closer to the age of the people that we're dealing with. I'm sure everyone in this room knows that adolescence can be kind of a complicated time. So our clinicians are not necessarily young. They're typically between the ages of like 25 and early 30s, but closer than a lot of the other people providing them care. This model's been successful at UH, and also think this will help with the dissemination of this model moving forward as we're training clinicians. Hopefully, many of whom will stay in Hawaii and be able to help to disseminate this. Our case management is helping clients with problem solving, solutions to practical problems, helping to coordinate care. This is provided by the clinicians and by the clinic supervisor, Elsa, and we're really involved in helping people with any problems that they have, fixing those problems. And we've in the few years that we've been doing this, we've really found the family guidance centers to be really helpful on this too. So clients who qualify for CAMD still have a care coordinator, and we try to stay in very close contact with them and pass information back and forth and make sure that if there's anything that's coming up, we can kind of use that as a resource as well. The next component is family education and support. So the idea here is that we are trying to help relatives, which includes parents, siblings, sometimes it could be a boyfriend or a girlfriend, whoever is involved in that person's life, and just kind of helping them figure out how to best help the client. So in the schizophrenia field, there's been a lot of research on expressed emotion, and it suggests that overly critical or trying to be too helpful, kind of paradoxically, can be problematic for kids. So we try to work with parents to kind of avoid those strategies and have more kind of appropriate strategies. And we try to include parents and siblings where appropriate in all phases of treatment planning. With respect to supported education and employment, we focus mostly on education. So as I mentioned, and I'll show a little bit of data in a few minutes. Our clients are all in school, either high school or college. We have had clients who have had part-time jobs as well, and we had one client who he wasn't working full-time, but very close to full-time, and he was only taking one class. And as an example of what we've done in terms of supported employment, with his permission, we actually wrote a letter to a job that he had been fired from due to poor performance that was probably associated with his psychosis, and wrote a letter that he was in treatment and getting better, and that we hoped that they would kind of give him another chance, and they did end up hiring him back. So that's an example. The rest of our work has been more related to education. So we do a lot of things that intensive and home therapists would do, like going to IEP meetings and helping to advocate for people, and talking to school counselors and helping them figure out strategies for what to do if our client is hearing voices during class, or if they need a break, and things like that. We've been working with the counseling center at UH Manoa as well. Some of our clients have come in having already been registered with them. Some of them have not been, and if they aren't, then we help them get registered. They're pretty good on their own once you get them in Kakua, so we don't have to do a whole lot there. We have aspirations to start a social skills training group. We're not quite there yet, but we've been doing a lot of social skill training with our individual clients. So we use Bellick's model, where there's a lot of role playing and things like that. It's been a challenge to get more than one client in a room at the same time. That's been the primary obstacle to groups. So hopefully when we have our new location and that's a little bit easier, we'll be able to get that set up. And there will be space there that's big enough for group settings. So I want to talk a little bit about data from our specific program. So far, the biggest source of referrals for us have been through Queens Medical Center, which I think makes sense because this is where people often go when they have acute psychosis. We've been working with the Department of Psychiatry and getting referrals from there. We've also gotten a lot of referrals from the family guidance centers directly. We've done some outreach, so we've gotten some referrals from private practice. We got a few referrals from Tripler, although none of them ended up being great fits for us. And then we've gotten a few referrals from neighbor islands, and we haven't been able to enroll people from neighbor islands yet. But we've tried to do things like writing assessment reports and trying to help with treatment planning. So of the referrals that we've gotten, a little over half we found to be eligible for the clinic, and a little less than half have been not eligible. And the main reasons for this, we don't have great data on the main reasons for this. So just in terms of our impressions, I think the biggest reason is when from in our perspective, the referral is more of a conduct disorder or behavioral problem than a psychotic problem. And from our perspective, it feels unethical to provide treatment to them when something like MST would be much better. So to give one example, our second client that we accepted had some kind of disorganized thinking, but after we got to know him a little bit and started doing treatment with him, it seemed pretty clear that the problems that he was having were more related to conduct disorder. He was stealing his dad's credit card and those sorts of things, getting in trouble at school, and he wasn't in a supported learning environment. And we ultimately just had to say we really think that MST would be better, and Candy was able to kind of get him into those services. The other reason for ineligibility seems to be that the psychotic symptoms don't reach that level of psychosis. So it's kind of a fuzzy line between prodromal and first episode psychosis. And we try to be flexible on that too, but some of the times we felt like to follow SAMHSA's mandate, we haven't been able to. And if there are questions about that, I'm happy to ask them, to answer them as well, and to hear any suggestions that you guys have about that too. So in terms of our school and work outcomes so far, so a little more than 2/3 of our clients are in high school, and a little less than a third are attending college. So when we're looking at this, we're really happy to see that all of our clients are in school or in college. Some of our clients have also had part-time employment, but again, we're not concerned with them having more than part-time employment, or really even having any employment if they're in high school or college. I wanted to talk a little bit about what kinds of additional services we can provide in addition to treatment. So this is if you refer somebody to us and they don't meet our criteria. So we typically do a full assessment with everyone that is sent to us. And we're happy to kind of write that as a report, help with consultation or treatment planning. One of the things that we've recommended to some of the people, particularly people who have prodromal symptoms, is that wherever they're getting treatment, they come back to us every 3 or 6 months, and so we can reevaluate it because it's episodic. So if someone is not psychotic at that point, then maybe they will be in 3 months, or maybe they will be in 6 months, and we're very happy to do reevaluations, and particularly if you see something's changing or anything like that. We would also be happy to do talks like this if there's any education or training we can do. And if there's anything else that you guys can think of that we're not doing, we're very open to suggestions as well. To reiterate that if you have any clients that you want to refer, we would prefer that you err on the side of referring too many clients to us, and we'll do the assessment and let you know what we think. So if you have someone and you're not sure, please send them our way, and if they don't meet criteria for us, then we'll do our best to try to help in another way. And I want to reiterate again that we're no longer ruling out affective psychosis. So we are accepting bipolar with psychotic features and mood disorder with psychotic features, or major depression with psychotic features. Here's our contact information. We also have some flyers that have this on it as well. This top one is our email address and our phone number for the clinic. And if you call this number or email this, then also we'll be the one to answer that. If you email me or my office, then of course that would be me. We also have information on our website on trackhawaii.org, and then this is the website for our lab, which is more focused on research. And then there are, as I mentioned, there are lots of people that have been involved in the study in one way or another for quite a long time, so I just want to thank everyone for that as well.
Thanks, David. So I'll introduce the panelists for today, and then it's pretty flexible. So how we've handled it before has ranged from initial thoughts and reactions from the panelists to not doing that, to opening up to questions, just kind of bouncing ideas around. So we can handle it however you guys want to handle it. It's just something to think about as I introduce folks. So a couple of people we have the pleasure of having here today, in addition to Dr. Cicero. I'll start off with Dr. Bill Sheehan. So Dr. Sheehan currently works for the Department of Health, Child and Adolescent Mental Division, as the psychiatrist at the Honolulu Family Guidance Center. He was originally from Toledo, Ohio, and moved to Hawaii in 1984 to complete his fellowship. in child and adolescent psychiatry at the University of Hawaii. He worked at Kaimohala as a staff psychiatrist and medical director from 1986 to 1994. Following that, he worked at Kaiser Permanente from 1997 to 2005 as a staff psychiatrist and chief of behavioral health services. Dr. Sheehan joined the Department of Health in 2005, working at AMD and the State Hawaii Hospital before moving to his current position at Candy Honolulu Family Guidance Center in January 2017. He is married and has one adult son and enjoys golf and karting. Welcome, Dr. Sheehan. Next, I'd like to introduce Dr. Daniel Alicata. He is the director of the Child and Adolescent Psychiatry Residency Training Program and an associate professor of psychiatry at the University of Hawaii, Johns A. Burns School of Medicine, where he's faculty since 2004. He earned his MD degree from the John A. Burns School of Medicine, and he completed his general psychiatry residency and fellowship in child and adolescent psychiatry with the UH Department of Psychiatry. Dr. Alicata collaborates with CAMD to provide mental health services via telepsychiatry, to children and adolescents throughout rural Hawaii. He continues to strengthen the Department of Psychiatry's commitment to address the severe shortage in child and adolescent mental health and addiction treatment services for youth and families in rural Oahu and the neighbor islands. So welcome, Dr. Alicata. Oh, okay. So that's our folks for today. So how do we, Dr. Slavin or anybody or any thoughts on, you guys want to give initial thoughts or just turn it over to folks for questions?
We can start with questions, is that okay?
Okay, I'll give a couple of
Okay.
comments.
Thank you very much.
Thank you. This is Bill Sheehan. Thank you. I appreciate the opportunity to be together. This is a really interesting topic to me. I'll just start out maybe just by sharing with you folks a little bit just of maybe historical context for me. So when I was in training in 1984, we didn't really get hardly any training on childhood or what the schizophrenia childhood type looked like. Very little actually. Many different things were like that. I mean, Asperger's and forms of autism were not like considered like they're now on the spectrum. Haldol, Navane, Trolofan, they were really difficult antipsychotics, first generations. You didn't really think of them too much, and they had a lot of side effects attached to them too. So they were difficult to use, hard on the youth, and weren't that effective compared to the side effects. So over time, I think, and I remember just for myself, remembering thinking about this when Risperdal first came out as the first antipsychotic, the second generation antipsychotic, and Zyprexa then came, and the other ones have come, because then it became much easier to consider treating what turned out to be prodromal or early signs of psychosis, of whatever the etiology, because this tool, the pharmacology, was much better. And then right along the same time, cognitive behavioral therapy came on the scene, and not just psychodynamic psychotherapy or Freudian kind of psychoanalytically oriented psychotherapy. So you had tools that were cognitive in nature as opposed to sort of open-ended, making things worse to just let people talk who are already having a thought disorder, to focus them in and help them learn. And the recovery model came in, and that also is a very practical, pragmatic way to help people stabilize their symptoms, whatever they are. So over the last 30 years, I think these developments in our field have really made this more, it's always been important, but it's more timely and more doable than ever. And I'll just start with that, saying this is a great opportunity and a chance to intervene early and frequently and persistently to divert them. Because working at the state hospital, you folks know who's at the Hawaii State Hospital, right? And by the time you get to that point, the $75 million a year that's being spent, $300,000 per person with marginal benefit is not where the money's at. This is, I think, where the cost effectiveness and the life effectiveness is to be found. So I'll just start with that. Dan, you've been around not quite as long, but
I'll come from the training and education part of it. I think the program has been a particularly rich experience, not only for us as attendees and supervisors, but for our trainees, our fellows, our residents, and working with the psychologists who are in training also. And this shouldering this relationship is also the way CAMHD is nurturing our development as providers in the community to really think outside of Honolulu, start thinking how do we address these enormous needs on the neighbor islands where we're having a poverty of available providers, resources, interventions. So our fellows who are involved in this program and our residents who are seeing some of the older clients, their feedback to us is that this has been an extraordinary experience. It's allowing me to be thinking about where, after I graduate, what can I do? How can I continue to work in the systems of care level of approach to the needs in the state? And then how do I start thinking about working outside of Honolulu? How do I start working on the Big Island or Kauai, kind of where we're seeing a lot of our kids being identified?
Thank you guys for those initial thoughts. Would it be okay if we open that up to questions and comments, folks? So, Albert, do we have a mechanism for Zoom folks to? They just start talking and then they'll just. Okay. So, so questions or comments from anybody in the.
So I missed the beginning. I don't think I need a microphone, but I missed the beginning, so I apologize. Is it an actual requirement that they be in college if they're of college age?
No. So that's one of our primary outcome measures. So it varies for client to client. So if the person has no interest in college, then we would focus on, ideally they would have interest in college or work, but we meet people where they are and try to go from there.
I have two more questions, but I'll wait until we get to you.
This is great if you use this because it's not only for the people in the room, it's for people on Zoom so that they can hear the questions. Thanks.
I was just going to ask if you could talk a little bit more about the social skills group, because I have this memory in my residency program. They would hand out the group therapist assignments just at random, and I just randomly got assigned, you're going to be the social skills group leader for the adults with schizophrenia. And I was like, I am? And I was curious if there's anything new, or what are you doing in your social skills group?
So we actually haven't started. I'm not sure if this is. We haven't started the social skills training group, but we plan to use Balik's model, which has been around for a long time. So it might have been the same one. And I've run those groups before, and it's a lot of fun. It's just you start off with there's usually two facilitators, and you start off by doing situations, and you kind of put people in these role play situations, and then just have people, very simple things to start out with, just asking somebody what time it is, or starting a conversation with a stranger, or in some cases, asking your doctor for something. And as it gets more and more complicated, then it gets to, how do you resolve a conflict with a roommate? And then you say, your roommate's listening to loud music when you're trying to sleep. How can you approach that situation? And usually, then you model it for the client, and then have them actually be the one to participate in it. There's also been in the last couple of years, some of the people that I worked with on internship were developing it, were combining that with cognitive behavioral therapy. So it's a cognitive behavioral social skills training. And we've purchased those manuals too, and we're hoping that once we can get more people in the room at the same time, we can do that.
That was always a barrier for me, getting everybody to come to group.
Yeah, it's a challenge, especially when when it's a clinic that's not long standing and having a lot of people who are always coming.
Thanks. Maybe we can. This one's louder. Maybe we can take a question. I know we had like 13 or 14 people on Zoom. Maybe we can try to see, purposefully fish some questions out from them. Looks like Dr. Slater has questions. I'll give this to her.
So I'm gonna have a little trouble making this into a coherent question, but I have to say I've been a little frustrated with trying to have CAMD youth take advantage of your program. I hear a bunch of the kids are college kids, and our youth often don't have much chance of really going to college right away. And I think we have these youth who have psychotic features, and they don't have schizophrenia, and it's not clear if they ever will. A lot of times I think they're really complex trauma kids, where the trauma reaction is so intense that it includes some break with reality. So I guess I just want to ask about, is there a way that On Track could be helpful to these types of kids, or what else would you suggest that we be doing with young people who are in this gray zone?
So with these young people, have you been referring them to us, and these are some of the people that we've said don't meet our criteria, or they've been people that you haven't referred because you weren't sure?
Well, I just know of a couple, and I don't know anything about the volume, where we've referred, they've been assessed by your folks, and like, no, they don't meet our criteria. We need to do something else with them. And that's something else is hard to figure out. So.
Yeah, I think and so I'm glad that you're mentioning that to us, because we want to be as helpful as we can. We've been been working very closely with KMD, and you mentioned that a lot of our clients are older than would be in KMD or in college. So we, to the extent that SAMHSA will allow us, we are able to work around those issues in terms of the severity of schizophrenia, because there is, in general, the treatment is really similar, and I would defer to them about the medication portions of the treatment, but for high risk or prodromal, it's the same model. It's the same coordinated specialty care model. It's just the medication recommendations are a little bit different. So I'm not sure if this is that helpful of an answer, but I would definitely encourage you to keep referring them. And if there are people, especially if there's a need that we're not getting, then we would be more willing to kind of be flexible on those criteria.
So Dr. Slayton, it was a very clear question. Thank you. So we have a fair number of clients, patients who are either young teens, 14, 15, in school, first episode, psychosis, some with trauma histories. And I think I like the idea of CAM-HD kind of an integration with On Track, where we're seeing a lot of coordinated care and services, not only in parent education and intervention in the home, but also On Track's intervention outside of the home. But then also it allows us, for those patients in those situations where psychosis isn't clear, then if CAMI or On Track is aware of these kids and families, and then they will also be ready to then reassess or then participate in intervention when psychosis becomes a lot clearer. I know that David had mentioned a little bit about the Neighbor Island vision, and we have a fair number of kids who are leaving acute hospitalization at Kahi and at Queens, and going back to the Big Island and Molokai and Lanai, and that psychosis continues to ember and drive the trauma also. And so we all have to follow these families and kids incredibly closely. And sometimes, medication, just compliance with medication is one of the biggest challenges. Some of our kids are leaving acute hospitalization on clozapine, and that puts another curveball in the craziness of trying to maintain compliance with treatment. And then a lot of our youth are happy on long-acting injectable antipsychotics, and they're doing remarkably well. And the studies are showing in schizophrenia the outcomes really improving with more compliance with medications and long-term follow-up. So I don't know, it's a big challenge. I appreciate your question. I think we're seeing a lot of opportunities in how On Track and CAM-HD are really kind of getting a sense of how integration is kind of evolving as we move forward, especially as we start thinking about Neighbor Island needs. CAM-HD is that's the kind of the center all the neighbor islands, the family guidance centers where our kids are getting care.
Well, I love the idea of really the family psycho ed piece. It seems really important.
It's critical.
Maybe we need to think about getting more of that kind of intervention out through our intensive home-based therapies. We could think about training around that together. That might be really helpful.
And just to add to that too, if we're kind of thinking outside of the box a little bit too, if there's some kind of if there are clients where something like that would be really useful, then maybe we could provide that portion of our service without them being
Getting
kind of in
into
the
the
whole.
whole-
Yeah, because I think there are some. I mean, what our concern is kind of being accountable to SAMHSA if they come in and say you're treating these people who don't meet the requirements exactly. But I think there are ways of still being helpful even if it's not kind of explicitly with that.
Well, and SAMHSA might like to see that actually.
Yeah.
Yeah.
So that definitely sounds like it's the beginning of a great conversation. Sounds like definitely it's not an all or nothing kind of approach. It sounds like there's a variety of ways. I'm getting text messages from people on the VTC saying, "How come you're not letting me talk?" So let's turn it over to.
Okay, excellent. Hi, I'm Madeline from Quad Family Guidance Center. So continuing on that discussion about the neighbor islands, what kinds of things are the barriers to having the same kinds of services or similar services available to the neighbor islands? I just wanted to preface that a little bit by saying, though, that we have been in touch with On Track Hawaii on a couple of cases, primarily for consultation purposes, so that we could sort of know how to begin to address some of the issues here on island around especially school and some of the vocational things. But in thinking even more broadly, how could we begin to transfer some of the services that happen on Oahu over to the neighbor islands?
So I think the primary barrier so far has been with having a well-developed, coherent plan about how to implement it on other islands, and thinking about the best way to do that in terms of whether we would start with one island or whether we would offer it to all of the other islands at the same time, and doing it in a way that's equitable. And so I'm not sure if there are specific barriers just yet. And I know Dr. Alicata has a lot more experience than I do with providing VTC services, so maybe to talk a little bit about that.
Yeah. So I think, Alan, I think also your question is very important, and I think it is the foundation of a lot of discussion from On Track on how do we look at what CAMHD's existing infrastructure is, such as Zoom and on-site visitations, on-island visitations, meeting with your teams, meeting with your clinical directors, Drs. Grande, yourself, and Dr. Hamamoto, and see how can we best, how can On Track best integrate that level of service as well, and then combining that or integrating that with existing CAMHD services. I'm also very interested to learn a lot about each of the family guidance centers where they're limited in resources, and all the islands kind of have their own kind of array of care and services and access to providers, but some I'm finding are kind of without a lot of resources, and I think that's where we can kind of think about how to kind of build on that. But again, the challenge of the neighbor islands is, how do we integrate and how do we develop the infrastructure? We're all users of Zoom here, and we were just talking a little bit earlier about how Zoom has opened up the opportunity to provide clinical care in remote and distant sites. Our families are very happy with Zoom. Our kids are remarkably happy with Zoom. It's amazing how fast they pick up the technology and how comfortable they are with the technology. And I think many of our children have gotten trained in the DOE. I mean, a lot of the remedial curriculum has been done by video. So I think we're looking at some challenges, but I think they're very, they're very doable. And I think having kind of initial meetings and looking at the available resources and looking at how best to optimize the care will be important discussions going forward.
May I follow up with a little bit more? I think that because of Zoom and the connections with the residency programs, we actually are in pretty good shape in terms of the medical side of the model. What would it take to incorporate the vocational and educational, or expand the potential and the capacity of the psychology side and the case management side? Is there a lot to that we would have to work on in order to take advantage of the entire model?
So I think that it would be actually pretty similar to the medical side. There isn't necessarily anything much more complicated about, or more complicated at all about psychotherapy over BTC than anything else. So I think it could still work. There would be complications with things like when we go to IEP meetings and things like that, which might be difficult. But I'm sure we could find ways around that too, by phone or whatever else we could call in.
Is it also possible to, David, or I don't know, Maddie, if there's an interest, but one of the things that was on your slides was just even assessment services. So I don't know, on the Camden end, to what end you might say, we wanna knock them up gold standard psychosis-based diagnostic assessment. I mean, would you guys be? I'm just throwing it out. I put you on the spot, but I mean, is that just an assessment only? Is that?
Yeah. So to repeat the question in case people on Zoom didn't hear, so Brad asked if we can do assessments for neighbor islands, and yeah, we're happy to do that, and we've done that a few times for on Hawai'i and on Maui, and I think that's easy to do, and that's something that we're capable of doing now. So I think we, as a clinic, I think all of us really enjoy the assessment piece a lot. So please, if you have people, send them our way, and eventually we do hope to be able to do the full model, but we can definitely help with assessment now.
So in the meantime, it'll be another pair of eyes, other people weighing in, another diagnostic impression, evidence-based practice recommendations, those kinds of things.
Yeah.
Great. Okay, still working. So any other questions from people in the room? Thank you for using this. Now they can hear too. Thank you very much.
So I guess my question is for Dr. Sheehan. I work in the schools with the elementary students as a behavioral health specialist, and some of the children who have the diagnosis of autism are receiving Risperdal and Abilify, maybe not at the same time. But I'm wondering if you know anything about, or what you can tell us about, the long-term effects of those strong medicines on the children who start so early in life, please.
I'll be happy to tell you what my thoughts are, and Dr. Alicott or anybody else can combine too. The newer medications are much safer in the long run and the short run than the older ones were. But any medicine in psychiatry has risk. And the ones that are Food and Drug Administration approved are thought to have a risk that is at a low enough level that it's approved for use in a young person. In other words, they've been studied, they've been analyzed, the government's reviewed it, and anything that would be prescribed for a youth generally has been tested for safety and effectiveness in that age population. However, there is still risk with any kind of medication that you use, and often you have to outweigh the risk of using the medicine with the risk of not using it. And it's oftentimes a 60-40, 55-45 kind of thing. You have to just make a decision and go with it. The long-term effects are possible. Some people take medicine for many, many years. We don't seem to have to worry as much about tardive dyskinesia, this funny, very serious movement disorder that could come from the old ones, but it can happen. These newer ones tend to have more problems with metabolic problems like diabetes, weight gain, and the consequences of that. The other thing that's a factor, you mentioned autism, so probably none of the antipsychotics have an indication, or Food and Drug Administration approved indication for autism, but perhaps a symptom, irritability associated with autism, and they may be used for that. Then you move into the category of what's called off-label use of medication, and that's where you can, it's not approved by the Food and Drug Administration for this particular reason, but you can use it because there's evidence base to support it. It's still got risk, and you always have to do informed consent, telling the family and as much as possible the youth to get both consent and assent from the youth to use this medicine, knowing that there are some risks compared to the risk of not using this medicine or using other treatments in their stead. So it is something that I use a lot and have used for many years, and there are problems and difficulties that can come from it. But generally, the benefit outweighs the risk, but not always. Each person becomes an individual case. Dan, I'll ask you if you like comment on that too.
I'll comment on the consent component of this, and to address your question as being a behavioral health specialist, in school. I think for us as providers and training kind of the new development of future psychiatrists in the community, consent really involves the family and the youth, but it also involves the constellation of treatment providers. So it's the school staff who needs to be a part of all of our follow-up meetings to learn about what side effects to watch for, what indications do we need to call to notify somebody about, what things to be thinking about when the youth comes to the office and has a complaint. So we make it a routine part of our consent process that if we do start a medication with the youth, it really is thinking about the biopsychosocial model, cultural model. If we have to bring in, the whole treatment team to discuss medications, because if it's a Neighbor Island case, the complications of getting medicine to a youth who maybe has run out is not as simple as just going to the pharmacy picking something up. Because a lot of our Schedule II medications we still have to fax, or we still have to hand deliver. So a lot of kids maybe go for weeks without taking their medicines, and you never hear about it until their next visit with the doctor. We're trying to minimize that. We're trying to make sure that, if there's, you've got a 7-day warning that the youth is going to run out of medicine, let's let the team notify each other and make sure that we're on the same page to make sure that those issues can be addressed ahead of time. And that's part of the whole consent process. Consent is, what are the indications for treatment, the side effects, the adverse events, the risks and benefits, but how do you maintain treatment along the way is also part of the consent process. How do you deal with all the challenges that are going to come up? And you want to talk about that ahead of time before they arise.
Thank you. I think we have a ATC question from Kim.
I just wanted to comment that I appreciate the family education and support component of the on-track, and I was curious to know what the delivery of that section is. Like, what does that look like? Our family is responding.
So it's a good question. We found that there's a lot of variability in terms of how interested the families are in that. I kind of went into this assuming that every family would be excited about that piece and would want to come in and do it, and some are, but some it can be difficult to get. Everyone's very busy. It can be hard to get mom and dad to come in sometimes. But the way that we typically do that is, I run those sessions personally with the person who's the individual therapist for that client. So the two of us kind of run that with the family. Most of the time it's mom and or dad. We've had siblings, particularly if they're older siblings, come in, and that can be really useful too, because that's a significant source of support and influence on the clients. So it's really we say family psychoeducation and support. There's a manual that we use that starts with just really basic. This is what psychosis is. This is what treatment is. We don't spend a lot of time on the medication piece because I think so our clients are tend to get everything they need from meeting with a psychiatrist. But there's psychoeducation about that, about what the side effects are. And then within each of the sessions, there's also time to kind of troubleshoot problems and issues that have come up since the last time there's been meetings. I hope that answers the question.
So if a parent has a question, kind of like something's happening that evening, and then they want to get their question answered, or they want to share what the experience that they've had, is that something that they would wait for the next appointment, or is there someone that they call, or how does that look?
So they have the option of calling, and we get back to people pretty quickly. And Elsa takes care of a lot of that kind of day-to-day things. If it's a non-clinical issue, so if it's something about they need help with a particular case management thing, or if they need to speak to us, we're available most of the time as well.
Okay, thank you.
I'm just wondering, I don't think I missed it, but do you have some data about how many kids how many young people you've treated, and how many have been referred, and any outcome data?
We don't have the exact numbers of how many. I think it's probably been around between 20 and 25 kids who have been in the program in the last 3 years. It's lower than that now, but that have come through, and so we're still in the process of kind of standardizing all the outcome data and making sure that part of the clinic is moving along smoothly. But so we don't have exact data now, and we've the issues have been that we've been tracking different things with different clients. So some clients we've been tracking. We've had clients who have started out with us not going to school at all, so we've been tracking days in school. We have other people who are experiencing hallucinations. We've been tracking that. So we're working on kind of getting it standardized so that there are certain measures that we're tracking with everyone so that we can report back.
I'd like to make a follow-up on that. And it's been sort of an invisible thing, but since I've been at the John Novice Mental Division and been aware of the program, it's been my observation that the index of awareness has been raised considerably. And Madeline, I'm thinking about your remarks earlier about Kauai. And even though we're in Honolulu Family Guidance Center, we're still, in a way, a social island. And we track, we're very sensitive, and I really believe in early treatment. Matter of fact, let me comment on prodrome. You only know it's a prodrome after the person develops whatever they're going to develop. And you look back and you say, oh, they were in the prodrome. So I like to think of it as an at-risk mental state, and it can go any which way. And I got notes here that I've seen people with what I thought was OCD, PTSD, disruptive behavior disorders, schizoid, autism spectrum. And they turn out to have that, or some of them turn out to have schizophrenia. So we keep following these youth, and the index of suspicion is high. But when we talk to them actually about a referral, it's as if we're on an island too, and they, well, no, we're kind of okay, no thank you, or the kid doesn't go to school, or doesn't come into the appointments, or we follow them, but to move them another step is very difficult. So I think for us, I'll speak to Family Guidance, Honolulu Family Guidance, we track all these youth, and we are probably treating them better and maybe more comprehensively with the benefit of your knowing you're there and the information you've already published combined with the formats like what we're having today. So we treat early, and oftentimes often antipsychotics, even when I'm not sure that they have schizophrenia. Sometimes it's extremely helpful, and sometimes it just doesn't work at all, and we want to let them stop it. So there's probably way more people been touched by the program than maybe directly in it. If that's similar to what other people have had.
Yeah, I appreciate hearing that. And if there are, and this goes for any of the family guidance centers, if there are people who could potentially benefit from us coming to you, we're more than happy to do that as well. We've had some success with that in the past with the Family Guidance Center out in Kapolei, and then also at the Honolulu Family Guidance Center. Just for people who are hesitant for the referral, we can kind of show up and let them get to know us a little bit, and just kind of tell them what we do. And sometimes they want the referral, sometimes they don't. But
terms of census right now, David, you guys have
We're
slots.
low right now, yeah. Yeah, and we're planning some more outreach when we move to the new location. We're gonna try to do press releases and things like that to try to get more referrals. We've kind of been holding off on that now, but we definitely could use more referrals. So if you have anyone, please send them our way.
So I think maybe we'll do one last question, either in the room or via VTC.
Speaking of data, what is the capacity that you could serve? And what plans have there been in place to interconnect with DOE in order for even teachers to be able to identify and immediately connect rather than not know what to do?
So I can tell you a little bit about what we've done, and if anybody has suggestions, we would love to hear that too, because that can be a challenge, especially with working into DOE. We don't have a specific upper number. When we started talking about having 16 clients at any one time, and after doing it for a little while and getting to know the engagement of clients, I think we could do more than that. So probably more like 25 or so. I think we could handle. In terms of working with DOE, the things we've done so far have been mostly kind of organically through having the client, and then we go to the meetings and we kind of get to know teachers. I've done a couple of presentations for. I'm not sure exactly what the organization was, but there was a presentation where there were a lot of behavioral health specialists there. I've gone to high schools and given presentations there as well. And if anybody has any suggestions for how to do more of those kind of things, I think those are really useful. The limitation is just kind of having a foot in the door and having people willing to listen to me talk.
And also, as the Department of Psychiatry and its training program is working even more closely now with On Track than they had in the past, if David and the team tells us that there is a school that's interested where there's a client at the school, we could also participate in in-service presentations to the teachers, the SSCs, the SBBHs, all the folks that really do work with our CAMP-HD kids on the school campus.
Great, thank you.
So I think that brings us to a wrap for today. If we could give a round of applause to our presenters. Thank you very much, everybody.